I would first of all like to welcome everyone to our today's webinar, Expanding the Role of ERG in Ophthalmology from the Genetic Disorders to Acquired Diseases with Dr. Amithavikram Hathibelagal. I'm very, very happy that we can welcome him today with us for this webinar. I'm very proud that we could get him because he's a very, very experienced ERG specialist exploring how the retinal diseases work, how they progress, and he's using psychophysical and electrophysiological methods to assess all this. And today he's going to share a piece of what he learned about how to expand the ERG from a very research specific setting into a more routine applications, into more routine diseases. So thank you, Dr. Amit, for being here today. Our program will be as following. I will first give you a short introduction how to ask questions. Questions are very, very welcomed. Please don't hesitate to ask any questions that you may have. Then Dr. Amit is showing you his work, his research work. Thereafter, I'd like to take just 3 minutes to show you how the actual ERG with the Retinal can work. I'm very happy that I have today a test patient with me. She's joining us then after the presentation. And after this very short demo, I'm very happy to discuss with you about all questions. With that, Dr. Amit, I'd like to hand over to you.
All right. Good day, everyone. I would like to first thank Ulrich for giving me the opportunity to present the work. And in fact, we met during the ISF meeting earlier this year, and then we sort of interacted, and that has led to this webinar. So thank you, Ulrich. So today I will be talking about, as the topic suggests, expanding the role of ERG in ophthalmology. Typically, we know that ERG is very vital in inherited retinal disease cases, and people usually think, okay, ERG means it has to be retinal dystrophy. So that sort of very closed mentality is there. But today we will try to expand that thought process and see that there is many other applications for ERG beyond the genetic disorders. So to start off, where I work, so this is LV Prasad Institute. This is where I work as a scientist as well as an electrophysiologist. So today's talk will have these broad themes, starting from basics and the use cases in IRD, and then we'll talk about retinal detachment, what happens before detachment, after detachment, how is the recovery, and also a very important role, how does the ERG play a role in diabetic retinopathy or diabetic macular edema treatment as well, and also the on and off pathways, which has become like more and more prevalent and significant these days. We'll touch upon what is the on and off pathways and where are these used for which diseases, and then in the context of myopia also we will look at how these ERGs are useful. So with that background, moving on. So we know that electrophysiology basically involves testing the electrical potentials. So which means that we need electrodes to start with, right? So there are different types of electrodes. As you can see, it starts from Z electrode, gold foil, and we have the DTL, Retinal. And so there are different types of electrodes, and you also have a skin electrode, that is, you can see in this patient is a skin electrode. So what these different types of electrodes allows us is to measure the electrical potential from the eye, and each of them provides a different sort of comfort and different sort of electrode amplitudes. So on the right hand side you have the overall amplitudes that you would get with different types of electrodes. You can see the ones that is placed on the contact lens, like a Retinal would give much higher amplitudes compared to something like a DTL, which is a thread-based electrode. And then the lowest is for the skin electrodes, where you would still use useful, especially for children, where they don't cooperate for the contact lens or the thread electrode, where the skin electrodes are useful in children. But you still see the pattern, however, the amplitudes are much lower using the skin electrodes. So the typical ERG setup consists of something like this. What you see here, we see a GANS field, and the GANS field can be in one of these formats. So it can be either big or small, depending on the type of the setting that you are using. And then we need electrodes, and then these signals from the electrodes are amplified, and that is actually fed to a system. So this is what is usually a typical ERG setup, such as what you see here on the left hand side. But whereas here the handheld device, everything is incorporated within the setup. So this is the GANS field, and here we have the electrode, and this is the connector. And this is what Ulrich will later show us in the demo. How is this performed using the handheld ERGs? So the basics first. Here we have two waveforms. One is dark adapted and is light adapted. Depending on the dark adaptation and light adaptation, the amplitudes and the waveform characteristics vary. On the y-axis, we have amplitude, which is in microvolts. On the x-axis, we have time. So the time to peak is actually measured from the flash point where there is light is turned on, and then this is the red line, that dotted line shows the A wave amplitude, and similarly for the B wave as well. So the characteristics are different for dark adapted and light adapted waveforms. Today we will be focusing more on the light adapted aspects, looking at what is the amplitudes or what is the peak times that gets changed or gets altered with different retinal diseases. So with that, we will move on to inherited retinal diseases. So what is the typical waveform that looks like? If you see on the top row, we have a normal subject showing the different waveforms. This is dark adapted 0.01, which is the first waveform. And then we have DA3, and then this is DA10, which is the light DA at 10 candelas. And then we have LA3, and then this is LA flicker. So this is how a normal should look like, waveform should look like. The amplitudes, so this is actually based on skin electrodes. So the amplitudes would be accordingly consistent with the skin electrode measurements. And also this is on a dilated pupil. So those are the basics that need to be kept in mind, because if you are not dilated, then the amplitudes actually decrease. So here on the bottom panel, we have the RP patient, where you can see that the responses are flat for the dark adapted, and the light adapted also reduced, but it is not as flat as the dark adapted. So there's a very minimal response present in the light adapted flicker. So, and then let us look at different other diseases in the retinal diseases. For example, if you see here, again we have normal ERGs on the top row, and then we have the different dystrophies on the each of these rows. So if you notice, one of the important findings that we need to remember is we are talking about this specifically about full field ERG here. So full field ERG is usually not affected much when there is only macular problem. You can see there is some response present for the second row. If you are observing, you are seeing that there is still responses present, and only for the pattern ERG there is a reduced response, because pattern ERG is macular function it captures, and that's where it is reduced. And looking at cone rod and rod cone, So the word that comes at the first is the one that gets affected more. So if it is cone rod, cones are affected more. So you can see there is cone signals are actually reduced. And if it is rod cone, so the rods are much more worse than the cone signal. So this is the brief preview of use of ERGs in inherited retinal dystrophies. Now let's switch gears and move to some acquired conditions. So retinal detachment, I'm sure all of you have heard or seen those patients who have retinal detachment. So what I'm going to do is use the disease to sort of explain what happens with the ERG process itself. So we know that in the full field ERG, the retina in the macular region, the region that is contributing most is actually the overall global response. So if there is a small changes or small pathology in the retina, the full field ERG is not affected very much. You can see here on the right hand side different retinal detachment cases, and depending on the how much the detachment is, the amplitudes are reduced accordingly. If the detachment is very only pertaining to one quadrant, you can see there is a small reduction compared to normal. But if it is a larger detachment, then there is a much larger reduction. So only when there is a total detachment, then there is a reduced response. So this sort of indicates that the amount of affected area determines the amplitude of the responses, ERG responses. So typically what we do for retinal detachment, usually there is some vitrectomy done. And here I will just show you what happens during the vitrectomy procedure also when you perform a ERG. So let's say if you look at vitrectomy, start, there is flicker responses present, and then you see that after vitrectomy there is a slight reduction in the responses, and then there is a in between while the exchange is happening there is a much reduced, and then after recovery then slowly the function sort of comes back. So let us look at patients who have had RD surgery. More specifically, this is only during this just a 5 day after surgery. Let us look at slightly longer duration. So here we have this is our work actually. Some of the work that we did last year, it was presented at RO last year. We have this patient who had underwent pars plana vitrectomy, and then we have this procedure that was performed on the right eye, and you can see the vision was actually 20 by 20 after surgery, which is at the time of testing. So the left eye almost serves like a control eye, and the right eye is the affected eye. And we are looking at 9 months post retinal detachment surgery, and you can see that there is, like, I don't have the pre, so I can't say there is a recovery, but I'm sure if the RD is huge, then there is almost flat responses. And now compared to the left eye, you can see there is slight reduction in the LA 3.0 and also for the LA flicker responses compared to the left eye. So this suggests that you can get a sense of what is the visual outcome. Despite the acuity is 20/20, the function of the retina has not yet fully reached the full potential. Right? So there is some amount of recovery that is probably, if we follow this patient again over a much longer period, maybe we will see the amplitudes also eventually catching up. That we don't know at this point of time, but it is possible that amplitudes will continue to improve further. So with that, we move on. So diabetic retinopathy is something where there is a lot of work, especially with regard to ERGs. And what we will do here is look at the different topics or different concepts that are there associated with both early detection as well as in the treatment outcome domains. So here we have something called a DR risk score. That is something that developed uh, by the researchers recently, looking at what is the risk score for the predicting the DR that is actually happening. And what goes into achieving this number is, so you look at the implicit time and the amplitude of two different stimulus, looking at 16 and 32 trolins, looking at what is the implicit and amplitudes of these, and also the pupil area ratio between the 4 trolin and 32 trolins. So using these parameters and also age into consideration, so the DR score is computed. So the higher the DR score, more there is a risk. So recently, the guideline also suggests that, so if the score is less than 20, then the progression of 6-month progression and 1-year progression is shown here. So if the scores are about 27 or more, the progression risk is about 50%. So progression to VTDR. VTDR is vision threatening diabetic retinopathy. So based on this grading scale, there is potential to tell what is the risk of progression. And also we have risk of ocular intervention also, that is shown using the DR risk score. So that is what I will explain now. So the same metrics is used, but here it's a longitudinal study. So before we move on, we'll look at also how the DR score is used in looking at the severity of the disease itself. So we know that using the fundus signs, we can tell, okay, whether it is mild, moderate, severe, or PDR. And also we have ERG signals. So this is mostly the flicker responses at 16 and 32 Troland. You can see that the responses are considerably going down as the disease progresses. In fact, the severity, according to severity, there is a error score where it has been plotted showing that there is an increase in the disease as on the x-axis, there is an increase in the DR score on the y-axis. So with that, we move forward. So how can we use these DR scores to actually predict the uh, who needs ocular intervention? So here we look at some longitudinal data. So before that, both retinal and structural measurements were done. So those who had VTDR, 31% of them actually progressed to a treatment. They need a treatment. But when you add this functional data, which is the data that we have obtained from the ERG, then what happens is it tells the risk of progression. If the ERG is abnormal, what proportion of these individuals potentially require treatment? You can see here on the 2-year progression, 50% of them actually need ocular intervention if their ERG is abnormal. But if the ERG is normal, then only about 4% actually require the treatment. So it sorts of gives you the information. Okay, you are looking at the fundus, you have that information. But if you couple that with the ERG scores and the ERG values, if it is normal or abnormal, based on that, you can put people, okay, this person is at a high risk of progression and this person is at a low risk of progression. And depending on that, those who are at a high risk can be called up for much shorter follow-up. So this is one of the useful things that we have in addition to what we can do in terms of looking at early detection. We can also use the ERG to make a prognosis to say, okay, based on that, the potential risk is going to be higher or lower. So similarly, now that we have seen what happens in patients before things go wrong, but here we are showing what happens to patients when they are having, proliferative diabetic retinopathy, where things are in a much severe stage, and based on that, what happens. And you can see one of the things that you can notice is there is this B by A ratio that actually is altered, and what percentage of these patients have this criteria. So this study has shown that there are different groups, group A, group B, and group C. Based on the different groups, we can actually say which group actually is more severe or less severe. In fact, about close to 50% of them fall under group C when the patients are having vitreous hemorrhage. So this sort of gives you also on a scale of the functional level where is the retina status before the surgery. And then now when you have post-operative ERG, that sort of tells you where is the improvement or how much is the improvement. So the other thing that I keep telling is, okay, you can diagnose it early, you can use it as a prognosis, but what about as a treatment outcome measure? Because often what happens is with visual acuity, the patient undergoes anti-VEGF injections before, and then after anti-VEGF injection also the patient seems to have having same visual acuity post anti-VEGF injections. So what happens here is the clinician thinks, okay, the OCT thickness has reduced, so the edema is resolved. So what happens is you should expect the patient to be happy. However, they see that sometimes the patient is still not happy with the outcomes. So they are actually wondering, okay, what else is actually is going wrong, or what else is that is not being captured clinically, that we are not able to tell that, okay, this person, even though they might be having 20 by 20 acuity, what else is missing. So that's where we are looking at trying to see ERGs also, especially the light adapted ERGs, because light adapted ERGs are much more easier to be performed in the busy clinical environment where they don't spend too much time, just the light adapted part. And what we did was we used a handheld ERG, perform the light adapted ERGs, and this is data from one subject actually. And what we see is we look at the light adapted 3.0 and the LA flicker responses, and these are the pre responses, and the post is on the right hand side. The same patient, left eye, was given ranibizumab injection, and 3 months later, what we notice, there is an improvement in the LA 3.0 response and also in the LA flicker response. You can see this amplitude increased from 13 to about 33 here, and also here going from 16 to 35 microvolts. So there is a significant improvement that we are noticing post anti-VEGF injections in patients with diabetic macular edema. So this was the work that was presented earlier this year at the ISF meeting. So in other vascular conditions, what happens? So there is ERG responses are reduced. We know when there is a vascular condition. Also, you can see on the right hand side, there is, edema, there is detachment, all that, and then the ERG responses is reduced. But post treatment, when the retina is more attached and the edema is resolved, then you can see the ERG responses also improving post treatment. So with that, we come to the last part where we are going to talk about on off and ERGs. So before I go into on off, I want to start with what is negative ERGs and then lead on to the on-off story. So typically what happens with a healthy DA10, DA10 is dark adapted 10 response, there is a A wave and a B wave, but with a negative ERG, the B wave is reduced. So A wave is present, however the B wave is absent. So which tells that there is something that is beyond the post phototransduction, which is the inner retina problem, is what it reflects. And what diseases are common? So we look at the genetic reasons are mostly CSNB, congenital stationary night blindness, and then we have the XLRS and also the CRX. So coming to acquired diseases, we have melanoma associated retinopathy, where we have vascular occlusions, so which can also cause a negative ERG. So in a complete CSNB, what happens is only the on bipolars are affected. So the on wave is absent. And in a melanoma associated retinopathy, also it's same the on bipolars. This is the congenital and this is the acquired. And incomplete CSNB where both are affected. So what does a typical on-off ERG looks like? So normally what happens is when there is a negative ERG, it is worth looking at on-off ERG to see whether specific on pathway is affected or it is both are affected. So the typical waveform here we have the B wave and the D wave. So on response and off response. And the typical response is the flash is about a long flash. And this protocol is available both in the regular desktop version and also in the handheld version of the devices. And what it allows us to tell is whether there is on pathway defect or it is a overall defect. So here this is a normal response, and then here there are two types of CSNB: RIX type where A wave is affected, Schubert-Bernstein where B wave is affected, and this is subclassified as complete and incomplete. The Schubert-Bernstein is subclassified as complete and incomplete, and that's where you have complete will have the on pathway that's affected, and then incomplete you have both that gets affected. So that's the context of on off in in CSNB. And just tying it along, how does this relate to myopia? So there is recent studies that have looked at how on pathway actually stimulates the dopamine release, and dopamine is a stop signal for axial elongation. If on pathway is affected, so then automatically it decreases the dopamine and then it affects the axial elongation. So that's the proposed mechanism. Of course, there are multi factors involved, but this is the proposed mechanism for this theory. And in conditions where the on pathway is affected, there is there is association with high myopia also, and this is noted in animal models as well. And there are some theories that looking at where whether that bright light can actually help in control or protect against the myopia. So that is again a work in progress. So what recently it has been studied is, so the myopia makes the responses weaker in both on and off responses. So this on the left hand side is a typical on off ERG, and on the right hand side we have this work from Podel et al. So the left panel shows the amplitudes. As the axial length increases, the amplitude decreases, and also it makes the latencies slower in the on pathways, which means that if you see as the axial length increases, the latency also seems to increase. So that is the finding. And what is the summary? So in cases where there is complete CSNB, we have high myopia association, and incomplete CSNB where moderate to high myopia association, and the bright light exposure we have enhanced on and off suppression is something that is still in the exploratory stage to see whether using the on off mechanism whether we can control or affect the myopia progression or prevention. So that is the latest what we have. And with that, I come back to the summary. So we have seen what is the uses in inherited retinal diseases and what happens in retinal detachment cases, post retinal detachment where there is a recovery, and that can be quantified using ERGs. For diabetic retinopathy, yes, what is the measure used for early detection, and also whether the DR score correlates with the severity. And then the last aspect is whether ERGs can also be used as treatment outcomes in DME pre and post. And then we looked at what is the on-off pathways, role in CSNB, inherited retinal diseases, that is the CSNB, and then their association with myopia. So with that, I will end the presentation, and I will be happy to take questions. Thanks, Ulrich, for the opportunity, and yeah, I'm happy to discuss further.
Thank you, Dr. Amit, for this wonderful presentation. I think there were a lot of information. Even I learned a lot, especially about the on-off. And I have later on a wonderful question. I also see already some questions coming in. To remind everyone how to ask questions, please look at your lower button. There's a green, or there's an F question and answer button on your lower part of the screen to ask questions. And now you already see my beneficial, wonderful test patient. I take a very short moment to demonstrate how an ERG with the Retinal works. So I welcome Lisa with me. When we start a test, in principle, the first thing we have to do is to type in the patient information. I've already done this in the past minute, so device is already prepared. After you enter the patient information, you choose the type of protocol. And now coming back to what Dr. Amit presented, it could be the on-off test. If you have a question about night blindness, if you believe in CSNB, it's a CNB patient, or you rather go for a short flicker test to see if the retina is functional, like in the CLVO, or something which is specific to this device is the DR score to understand the progression risk of the diabetic retinopathy. Once the device is readily prepared, I prepare our patient. In the clinic, please always clean the skin under the eye to make the skin sensors, like this in here, fitting very well. I unpack my electrodes and different to standard ERG. You don't need to vary on cabling or anything else. All electrodes are already inbuilt in our stickers. I put them under the patient's eye. She's just watching straight. I put them centrally under the pupil and 2 millimeters below the eyelid, looking like this. I hope you can see that. And the second one coming in a second. Same procedure. I put the device on here. And then in the next step, I can simply clip the cable to the patient's eye. I say, start the device, and from now on, the device tells me what to do. I position the device over the patient's eye, wait until the pupil is correctly detected, It's very difficult to see. We are a little bit far away, but I see a little crosshair in the pupil, and then I start the device. My patient is watching straight, keeping the eyes open, and now we are running the test and measuring the data. This is the DR protocol. As Dr. Amit mentioned, we are collecting several intensities to complete the test. We give it a moment. We are almost done. Done with the first eye. And I go to the second eye to do the other eye. I clip the cable. The device tells me again, switch to the other eye. I say next. Turn a little bit like this. We'll wait until the pupil is tracked. And we are collecting the data. Whoop, my camera is moving along. And that's all the test. Thank you so much. After the test, getting the results to your device or to your PC is very simple. You place it into the base of the instrument. You connect it. You connect it, excuse me, my button. You connect it to your PC. And you get a PDF or a picture of your whole report. Let me show you how that will look. You should now see my presentation. And this is the report of her test. We see an overview of the patient information. We see the picture of the eye. The score that Dr. Amit mentioned, she is young and healthy, so as expected, she has a very low value. And if you're interested in the details, how the DR score is made up, you'll find the actual flicker results. That's in principle how an ERG with a Retinal works. I hope that gave you a little bit of an impression. And now I'm very happy to receive all your questions and discuss with Dr. Amit about the responses. I stop my screen so that we can see the faces a little bit better. I already have quite some questions coming in, so I would directly start.
Okay.
One of the first questions would be about doing ERG in children. There's a question about sedation with skin electrodes. Is there the need to sedate children for dark adapted, light adapted tests?
So it's purely dependent on the cooperation of the child. There are instances where we do sedated entire ocular examination, which includes refraction, fundus examination, and also we do ERG, especially in patients where there is very little cooperation, where we can't know what is their visual status, then yes. But if the child is cooperative, if the infant is cooperative, we can test like literally any age. So it depends on the cooperation level, and if there is a need, then yes, we need to do it under sedation. And it becomes easier because we have the handheld device, so we can take it to the OR if needed to do the testing. Previously, with the other devices, so we could not actually, measure the ERG responses.
I understand. So if just probably to summarize, I understand from your experience, if I remember correctly, you have the red valve for many, many years already. So the majority probably does not need to be sedated. However, there may be some patients that don't cope well and they still may require sedation. Great. Thank you so much.
Right.
Then another question refers, stays with the pediatric one. There's the question about the youngest age that you can do a test with the red valve in. What is the youngest age that you can do the test?
As I said, there is like we can test as long as they are cooperative, and especially we may need to use the smaller skin electrodes, not the regular skin electrodes, because their faces are going to be much smaller if they are going to be quite young. So it is possible to test even in a 1 month old or yeah.
So if you do need to give a number, there's no number. It's basically from birth on.
Yeah.
Wonderful. I just need to sort the questions here. There is one question which is made up of two questions, in fact. This is how can we read exactly the report and explain it to the doctor? And connected to this is if there is a difference between the conventional ERG reports, and this particular device. What are the differences? What to consider when switching from one device to another?
So typically, as I said in the first slide, the type of electrode determines your amplitudes. So if you are using skin electrodes, you would get lower amplitudes. However, there is a normative data that gets added onto the report. Usually, when you scan that QR code that you would see on the sticker that contains the electrodes. So it actually gives you the reference ranges. It tells you whether it is in the normal range, subnormal, or abnormal. So you have some database to rely on, and you would compare it against those values, not against your desktop setup values. So if you are switching, you would have your reference database along with it that comes along with the machine, I guess, and then that should be usable directly. Is that answer the question?
I think so, yes. So from my perspective, there's always when you switch, but that's not restrictive to ERG. I think that applies to OCTs, that applies to lasers, to other machines as well. If you switch from one device to another, there's a little bit of a learning curve to get accommodated to slight differences. When using skin electrodes, the amplitude is only 30% of what you're used with other electrodes. So these effects have certainly some impact, but as long as you have a good solid reference database, the clinical decision-making process is not different, or the clinical decision ability is not different. Regarding how can we read the report exactly and how to explain it to the doctor, maybe I can add a few little words to that. If you have an ERG device, especially ours, we also provide some material to how to easily understand each of the points. There's a little bit of learning in the beginning to understand what the waves mean. Dr. Amit mentioned that in the beginning. So the A wave is the photoreceptors, the B wave is the bipolar cells. If that's outside the reference values, that gives you a good hint already. It depends, or answering that question depends really on what disease you are looking at. So if there's something specific, we will always be behind that to help you communicating that among other doctors. And if we don't know the answer, we have people like Dr. Amy that may help you with the starting phase to work with that.
Okay.
More questions are coming in. So I now switch to still honor, probably I stay with the technical questions. If Dr. Amit, if you're fine, I will reply to that. Is there any protocol, any updated version similar to multifocal ERG for this Retival? Not for multifocal. The Retival isn't if Ganzfeld, full field flash ERG. It can do all kinds of ISF. Everything you can do with the Ganzfeld is possible on the Retival. You can do custom protocols. We have the inbuilt protocols, but neither multifocal nor pattern is available with the Retival. LKC itself has the conventional machines as well. You would need to add a conventional machine to have the full range of electrophysiologic capabilities in your portfolio then. But then for the next question, Dr. Amit, I can get back to you. Is there any problem if we use large electrodes for kids?
Large electrodes?
Well, actually, I know your colleagues have the small sized sensor strips. We do have two types of sensor strips. One is the
Right. Yeah, I know. The small
the
ones
big
and the
ones.
big.
So the question is, does it make a difference if you use the small ones or the big ones in kids?
I think it matters depending on the face size, especially if it is a very small baby and their face is also very small and then it covers up their entire face, then you don't get the right sort of measures. Like if you start at the center point where the pupil is and then you go forward, there is no face left for you to place the electrodes. So then sometimes what people end up is putting it closer to the nasal canthus, then both the electrodes on either end becomes like a reference, so you will not get a right response if it is used on babies which are whose face is very small. Ideally you would use slightly larger electrodes where that face permits you to place it in a proper direction that is provided.
Okay. Okay, I understand. I just quit that question. Then another question, moving back to adults again, or probably different disease. Do you think you could detect retinal detachment and follow on improvement with light adapted tests only? This person asking is assuming that you had dark adapted tests done for the retinal detachment patients.
We haven't done that for our cohort that I reported, but it seems like the light adapted do seem to improve post retinal detachment surgery, and that's what we are reporting. So I cannot comment whether the dark also would improve. Probably it will improve, but if you want to get a quick sense of what is happening at the cone level, overall retinal level, then light adaptation is much more convenient and feasible. But it doesn't mean that dark adapted responses won't improve. Even if you measure, then you might know.
I see. So in principle, a light adapted test is a very good indicator for
Yes.
anything around retinal detachment. There's one question about the normative database as it differs related to the age or the genes. What is your experience?
Sorry, can you repeat the question?
One doctor asked about the normative data. The Retival includes reference data, and the question is if the reference data is age related. So would you always pull an age-corrected data?
Yeah, it is age related because you need to enter the date of birth while entering the details. So it is age specific. And what was the other thing? Gene related.
Yes. the other one was gene-related.
I don't think so. That is gene-specific information you would is encoded in the database. So I don't think that information is there. Yes, age is encoded in the part of the database. And even if I recollect the conversations from other people from LKC, the database includes multiple ethnicities, not just Caucasians, is what I have heard from you guys.
Yeah, so maybe I can add to that a little bit. The inbuilt reference data is based on more than 500 patients across all ages, from 0 to probably 85 years old. The reports always pull up age-corrected data. There are a few tests that don't, but very specific tests that you generally don't use in the routine situation that don't have reference data, but the majority of tests have age-related reference data. There is maybe one, let's say, the only one that may be interesting to talk about regarding the age is the DR assessment. Especially in the DR assessment, if you have a very young patient, it may appear red on the DR score because the DR score was built on an adult population. If you now test like I did in a child, and if the results are red, we have to look at it with the age contribution. But apart from that, every test has age-corrected reference data. Then, if I think that question is fully answered, we have one more about on and off ERG with regards to myopia. Are there any scores similar to the R scores or other effective ways to forecast myopia progression in ERG?
I don't think we are yet at that stage where we have a similar risk score using ERG for myopia, but there is on-off ERGs and myopia has been recently explored more vigorously across many studies. So there may be some marker, but not a similar sort of score at this point of time. Yeah.
Okay, I understand. Thank you. There's one, again, little bit technical question. It's about the dilation status. The DR score we did undilated because it's also based on the pupillometry. This question refers to undilated tests for other situations. If the undilated pupil will reduce the amplitudes, then how do we do the ERG in any pupil defect patients, and how do we do the analysis of this data?
So specifically for DR paradigm, is this or is this?
No, I think it's for all. So when we look at the Retinal, we have tests that can do, or basically the whole question is driven by the DR question because we do that always undilated. But as we have all other standard tests in an undilated version, it basically refers to everything. But the question is caused by the DR test. And if you don't have a nice and round pupil, would you still be able to do that test? Or what would you do then in such cases?
I think it is from what I have seen and experienced, the pupil tracking is very critical to ensure the amount of light that goes into the eye. And if for some reason, if the pupil is not tracking properly or tracked irregularly on and off, then the test doesn't get completed. That is my understanding. I think Ulrich, if you have any other information.
In such cases, I think I would just switch to a protocol that uses dilated pupils because the device is then not relying on the pupil detection. And especially for the DR, the DR score may then not be available, but you could do the separate flicker ERGs as well to see how the retina is functioning. So, and then the evaluation and the data readout will be as you are used to because the reference data is also specific for dilated, non-dilated tests, and you can easily evaluate irrespective on pupil status.
Right.
So we only have 2 minutes left. We have 2 questions, which I think we can ask. Probably the easier one is, what is your experience with high myopia? With myopia eyes, how do they influence the ERG?
So in general, you would see the amplitudes are lower compared to the age reference. The second aspect is, if it is associated with retinal dystrophy, then it is much more reduced. So that we have to be sure if it is a isolated high myopia, or is it a high myopia associated with a retinal dystrophy, or a more syndromic type, like where there is a retinal association dystrophy, then the reduction is much more severe.
I see. Great. The last question is probably very complicated to answer. So it is, when the device measures the pupil size, what to do if pupil size recorded is different by 1 to 2 centimeters between the eyes. So let's assume you have a patient, the device tells you the pupil size, the right eye is, let's say, 2 millimeter, and the other eye, or 6 millimeters, and the other eye is only 2 millimeters. You have a huge difference. How do you read such a situation?
So I would say like it comes a little bit with experience. There is no quick answer to this. Like I cannot say add 20 microvolts. So there is no such easy answer. You just have to look at, do not misinterpret. Like if you observe pupil size, then the asymmetry you can account for. Like if the pupil size is small, then the amplitudes are lower, then you don't diagnose it as abnormal. You take a more cautious approach. I would probably dilate it to make sure both are equal and then repeat the test.
I see. I hope that answered the question completely. If not, I briefly share my screen. If that question had not been fully answered to the doctor that asked the question, please drop me a short line and I will further investigate how to best reply to that question. If you are somewhere in Saudi Arabia or Australia, you may meet us there. But with that, I would like to end that webinar. If there are more questions, don't hesitate to contact us. Visit our website or send me a message directly. To end that meeting, I would like to thank our audience very much to be with us for this hour. I would like to thank Dr. Amit a lot of times for this time spent with us. Thank you, everyone. Thank you, Dr. Amit.
Thank you, Ulrich. Thank you. We'll see you around. Thank you. Bye.
Bye.